Screening for fetal structural abnormality in the first trimester. Hello, I'm Fergus Scott and I'm one of the doctors at Sydney Ultrasound for Women. So why look in the first trimester? There are some advantages, including being able to date the pregnancy accurately, and this can be incorrect in up to 40% of cases. Occasionally, unfortunately, the pregnancy may have demised. Thus, we can sometimes find twins, and with this, to characterise them as monochorionic or identical twins, or dichorionic, which is the fraternal twins, is important. Major fetal structural abnormalities can occur in about 1 in 200 pregnancies, and that will be the subject of this webinar. Chromosomal abnormality is a screen for, including Down syndrome, and another webinar on this regarding particularly the nuchal translucency is available. An increase in the nuchal translucency, which is the thickness at the back of the baby's neck, can also be enlarged in babies with structural problems. So there is a catch with scanning in the first trimester, and that includes the fact that some organ systems develop later than when we're scanning. Certain anomalies can change. They look quite different later on, or they can in fact even resolve. And some abnormalities cannot be properly diagnosed until some time later in the pregnancy. There are limitations because of the early gestational age. The baby is very small. It may require transvaginal scanning, and a reasonable amount of time has to be allowed to assess the baby properly. Mother's size can affect the scanning quality. The sonographer experience is very, very important. And we can use the family history or the presence of the nuchal translucency being enlarged to identify a high-risk group. Detection rates in the first trimester in various studies have shown us that around about half of all major structural abnormalities can be detected, and the majority of lethal abnormalities. Certain abnormalities we are very good at detecting, such as acrania, whereas others, such as spina bifida, we're not very good at finding. An example of acrania is where the baby's skull bone, here is a normal fetus with the bone present, whereas here we see that same picture, however the skull bones are absent. And with this view we can see how the brain extends either side of the baby's face. Holoprosencephaly is where here the midline and the choroid plexus in a normal baby's head is absent. We have fluid in its place and just the brain stem. It's called a monoventricle, and this is associated with a chromosome problem called trisomy 13, also known as Patau syndrome. Heart abnormalities become much easier to detect as a baby gets further along in the pregnancy and therefore is larger. We sometimes need to look transvaginally so that we have better imaging, and our larger nuchal translucency will help us detect a heart problem, as that tends to be enlarged in babies with heart abnormalities. So as the nuchal translucency increases, the incidence of a heart problem also goes up. Detection rate of heart abnormalities in experienced hands can be as high as 64% in the first trimester, adding another 17% in the second trimester, and certain abnormalities can't be found until after birth. Here are two examples. This one here is where the left side of the baby's heart is much smaller than the right. And here we can see the two ventricular chambers and a defect between, and then going off into the two outflow tracts. Defect and the outflow tracts here. Exomphalus is where the baby has an abnormality around the region where the umbilical cord exits the baby's abdomen. So in a normal example, the abdomen has the umbilical cord exiting, whereas here the liver and bowel comes into a mass in front of the baby. Here we also have a nuchal translucency which is larger and indicating a higher risk of a chromosome problem such as trisomy 18 or Edwards syndrome. Gastroschisis does not have an association with a genetic abnormality, and with this we can see bowel loops coming out from the baby's abdomen. Megacystis is a very large bladder. A normal bladder is quite small but is visible, medium size and larger, and in measurements we use 7 and 15 millimeters as cutoffs. Under 7 millimeters is considered normal. Between 7 and 15 millimeters the bladder will frequently go back down to a normal size, but there is a high incidence of chromosome abnormalities. And when the bladder is very large, the incidence of chromosome problems is less, but unfortunately these babies rarely do well. Skeletal abnormalities, in other words abnormalities of the limbs and spine. Clubfoot is a classic example, though very difficult to detect in the first trimester. We can find skeletal dysplasias where the bones are very short, or sometimes spinal abnormalities. 3D ultrasound is useful, but there was a suggestion that we would be able to do a single sweep of the baby using 3D and then later assess it. This would have advantages in that we could reduce the scanning time and we could assess the baby at our leisure. The disadvantages, however, is that the imaging is not as good as our standard two-dimensional imaging. The detail is not as good, and if we needed further imaging from different angles, the patient had already left by the time that we knew this. Unfortunately, not all problems can be detected in the first trimester. That includes clubfoot, as we've previously said, cleft lip, and you can see other abnormalities here. It can also include issues to do with the cervix, which can become shortened later on, and with umbilical cord over the cervix, such as vasa previa, and that can be a major issue for the baby later in the pregnancy. So in conclusion, careful scanning by an experienced sonographer can detect the majority of major structural abnormalities in the first trimester. A second trimester scan is, however, still worthwhile. Thanks very much.